Okay, great. Try to go as quickly as I can. 10 minutes is really difficult, obviously, to cover this topic, which we could spend hours on, or days. And I'll do my best. Yeah, thank you. So we all know mammography faces a lot of criticism. It is a controversial area. And that's because it is an imperfect test. The sensitivity and the specificity are variable, and that is often due to patient factors, the age, the tissue density, hormones, and then the tumor biology, of course, with not all breast cancers presenting the same way. So it's really a balance of harms and benefits. And obviously the benefit, like we've been talking about with all this screening, is a reduction in mortality, but also I would say with improvement in morbidity as well. So the earlier detection, then we can have more treatment options. And of course then the harms include false positives, false negatives, the anxiety and costs involved with that, and overdiagnosis, which is an area of interest. So screening mammography, again, is the gold standard for what we use for screening for breast cancer. And why do we screen? We need to answer these questions. At what ages and how often? Okay, so those are the questions. Breast cancer is common, as Beth has shown. It is a common disease in women. 1 in 8 women will get breast cancer, so it is a major source of anxiety for women. The mortality reduction is, a range depending on the study and the randomized control studies, but we could say maybe roughly 30% as an average. Now, these randomized control studies were done many, many years ago with technology that is so out of date. Of course, that's not what we're using today. And I think those of us in breast imaging can get very frustrated when the USPSTF uses the randomized control trial data to base their recommendations on, when it really doesn't reflect the way we're practicing today. But of course, that's what they've got to work with. So honestly, I think with modern mammography that we're using today, could the mortality reduction be greater? Probably. Why do we do it? Well, if you look at the 5-year survival rate, of course, when you find cancers that are localized, you can see how great the survival rate is, okay? So this is what we want to do. We want to find breast cancers when they're very localized and very treatable, okay? As soon as they're more widespread regionally or more distant, of course, the mortality decreases. And again, as Beth mentioned, we're unfortunately in an area where we have a high breast cancer rate, so one of the highest in the country, okay? So for whatever reason, we have to deal with that. That's the reality. So what age and how often? These are the controversy over screening. Obviously, to work, it has to be done regularly. Again, as Beth said, younger women have more aggressive tumor biology. They don't have a higher rate of cancer as older women because the incidence does increase with age, but they get a more aggressive breast cancer. So again, this is the thing. Not all breast cancer is the same. Okay, so there is a need to screen the younger women more frequently. Older women, perhaps with no risk, maybe biennial screening is okay. We don't really know exactly, okay? Of course, the majority of women who do get breast cancer have no risks. So we can talk about risk factors all we want, but 75% of women, 3/4 of women who get breast cancer don't have any risk factors, okay? So what are our guidelines currently? Well, again, it's been very controversial, and we are keeping our eyes on this, but we have still been recommending annual mammography starting at age 40 for the average risk women, okay? Of course, this is a personal decision, and it should be discussed with individuals with their physician. And I'm going to get into some of the issues here. So what are the screening guidelines currently? It's all over the place. The American College of Radiology, American Colleges of Obstetrics and Gynecology have recommended annually starting at age 40, okay? And there are other, NCCN as well, of which of course we're a part of, has stuck with this recommendation. Okay, now last year, the American Cancer Society, just exactly last fall, a year ago, did come out with different guidelines. Now, they suggested, whereas they had suggested starting at 40 annually, suggested starting at age 45 with the option to start at age 40. Okay? If it was started at 40 or if at 45, until 55, it would be annual. Again, based on that, younger women have more aggressive tumor biology, okay? And after 55, then biennial, okay? Again, with the option to continue annual screening, and I'll get into this again. So that option is always there. The USPSTF recommends starting at age 50 and biennial, okay? With the option, again, between 40 and 49 should be individualized, okay? So all of these groups do allow the younger women to start, but again, it's a personal decision. So this is where there's a lot of decision-making here. In terms of stopping screening, it's, again, a variety of recommendations. Some of the, you can see it here, the American Cancer Society says as long as, of course, if their patient's in good health and the life expectancy is at least 10 years, American College of Radiology, at least 5 to 7 years. You know, if honestly I know I'm going to kick the bucket 5 years from now, I'd be really happy. Most people don't know exactly 5 to 7 years that, you know, when we're going to pack it in. So obviously those are sort of difficult to know. I think it really based on comorbidities and how healthy the woman is, because again, we don't really know the life expectancy. USPSTF suggests stopping at 74. Again, insufficient evidence to recommend for or against. Just to summarize some of the differences, because again, American Cancer Society and USPSTF are sort of the two main entities here making these guidelines that, of course, our patients are seeing. And so just to highlight this graph, this table just highlights some of the differences. Breast self-exam and clinical breast exam, again, that kind of went out the window a few years ago, whereas it had been recommended, it's not recommended anymore, and actually recommend against teaching. So really, again, mammography is our main source of screening. The American Cancer Society, again, the opportunity for informed decisions, but it should be annual in the younger age group, biennial in the older, as I've pointed out. What you will note here is that this was given a C rating with USPSTF, and that is where there's a little bit, obviously, of concern, because a C rating does not mean that it will get paid for. Okay, an A or B rating does. Now, there is a 2-year extension on this that mammography has to get paid for, so it is something that may change down the line that we'll have to keep an eye on, because, of course, if it is not getting paid for, that is going to certainly affect women getting screened. Okay, so annual and biannual, I'm going to talk about that in a little shortly. Again, how did they determine these? You know, how did they make these guidelines? The USPSTF really based more their recommendations on the randomized controlled trials, okay? Whereas American Cancer Society did take the randomized controlled trials into account, but also observational studies and less with modeling, whereas the USPSTF more with modeling. So this is some of the differences. So USPSTF is more on a population basis, okay? And the American Cancer Society more individualized. And you can see USPSTF really based more on, emphasized more the harms of mammography, whereas American Cancer Society perhaps more on the benefits, okay? Because it's all a balance of risks and benefits. Okay, so again, the task force based on the randomized control trials, which are really not done with modern equipment. The other important thing to point out, which Beth mentioned, which I think is really a critical thing, is these randomized control trials were all done in Europe and North America on white, non-Latino white women. Do those results even hold true for our minority populations, where the breast cancer is different? We know that African Americans and Latino women, they get breast cancer at a younger age. They get a more aggressive breast cancer. So I think, you know, if you're going to use that data, you have to use it on the appropriate population, and it really doesn't hold true for our whole population, certainly not our New Haven population. So I think that's really an important thing to consider. Okay, again, the harms, as I've mentioned, that have been perhaps emphasized, that we can talk about overdiagnosis, false positives, false negatives, and radiation risks are the harms of mammography. Okay, they only considered mortality, as I mentioned before. I think morbidity, as far as women are concerned, is very important. When I'm telling a woman, and I've done it so many times, right, that she has breast cancer, their first concern is, do I need chemo? I mean, that is their what they're most concerned about, is chemotherapy. So, if we can find small cancers and they can be treated easily with a lumpectomy and radiation, it really does make a big difference. So I think that is it's not just mortality. So annual versus biannual, really there have been no trials that have directly compared this, so we really don't know. The screening interval obviously is influenced by the rate of tumor growth, and then that is reflected on interval cancer rates. So we want to hopefully reduce interval cancer rates. So basically it's a trade-off between screening too much or not enough or getting it just right. And again, a balance with the false positive rates. If we do look at the data, again from the large Swedish two-county screening trial, you can see if you look, and these are the 40s and then the 50-year-old plus, if you look at the interval between screening, whether it's annual, biannual, or triannual, you can see the rate of interval cancers going up. So it's sort of a no-brainer, but we obviously want to reduce those interval cancers because those are bad, lethal cancers. Okay, so annual does have the lowest rate of interval cancers. And again, this study also showed the same thing, looking at annual versus biannual, and the women who had and the younger women biannual tumors were a higher grade and a later stage. So we do feel at this point, with the data that we have, that annual is better. Okay, again, if we are doing better with our screening and our screening methods, our technology that we have nowadays, maybe we are finding many of those cancers, maybe we can stretch that screening interval out safely, but we just don't have that data to tell us otherwise. So overdiagnosis is a big problem, or at least a big concern, a big topic of discussion. And honestly, again, I think that it is something that perhaps has been overblown, but if it gets perpetuated, talked about, people believe it. Overdiagnosis is detection of small or slow-growing tumors that are unlikely to cause harm or a mortality effect. So most of these are going to be the in situ tumors or some very small indolent invasive tumors, because most invasive tumors progress, okay? There's been no reported case of an invasive cancer regressing on its own. The overdiagnosis rate is kind of all over the map, and that's partly because we don't have really good ways to measure it or even to define it. Unfortunately, we can't differentiate the more lethal tumors from the non-lethal tumors, so we just find them, okay? And I think that it's important that I think most women would prefer to have the information and deal with it or treat it if they want, and then to not have the information and just stick our heads in the sand. Okay, so overdiagnosis is really something that is, I think, maybe overblown. And let me just want to point out, if we think of overdiagnosis as a cancer that's never going to progress, then it really doesn't matter what age or interval we screen at, because those cancers aren't going to progress, right? And so it really shouldn't come into this discussion of the age and the interval of screening for breast cancer, even though, like I said, it's been made a major focus of discussion. So again, I sort of feel like overtreatment should be more of the interest rather than just not diagnosing these cancers. So I just want to mention 3D mammography, because that is what we use at Smilow, and we have been using it since 2011, one of the first in the country, and that really has revolutionized how we are screening, because it really reduces some of those harms of mammography, particularly the false positives and even the false negatives. Okay, so 3D mammography, honestly, patients hardly know the difference. It still does involve compression, and it takes, and we take the same images of the breast. But then we can look at the images on the workstation in small slices, thin slices. So here's a 72-year-old. She has sort of moderately dense tissue. That's her 2D mammogram. And then the 3D mammogram, you can see that this is moving slowly, very slowly, again, 1 millimeter intervals through the breast. from one side to the other. And you can, I think, appreciate how much more information we can get than just a 2D image. So again, here's the 2D image, here's the 3D, just a single slice. Here's the cancer sitting in here. You can see this little spiculated mass. It's completely hidden on the 2D image. And there it is on ultrasound in an invasive ductal carcinoma. So there's multiple studies. I could talk for hours on this because it's a favorite topic of mine, but just to summarize, there's multiple studies now, single site, population-based studies that all show that tomosynthesis or 3D mammography lowers the recall rates and increases the cancer detection. And it's particularly invasive cancer, so that's a good thing. We're not increasing our DCIS diagnosis. Okay. But it's the invasive cancers, those ones that we're hiding in the tissue. Okay, so again, we can reduce the false positives by not recalling things that we might, that just would be superimposed tissue. And our recall rate has been reduced by half. So it's currently about 5 to 6%. Okay, so the vast majority of women get a normal report. False negatives, again, because it's increasing the cancer detection, cancers that might have been falsely negative on 2D mammography, again, are seen on tomosynthesis. And just looking at our data broken down by age, because that is obviously an interest, we can see that the accuracy is actually very high in all age groups, okay? We're talking in the 90s. Now, if we talk about 2D mammography and dense tissue, we're talking in the 50s, 60s. I mean, so this has tremendously changed how we are practicing mammography, okay? And I'm going to just skip over these because women with higher risk, we do have other things like MRI that we can screen with, and ultrasound, particularly where there's denser tissue, but that's, again, a whole topic on itself. So just to skim over that. So the issues are complex. It's really hard just to do it very quickly like this. I think basically the randomized control trial based on antiquated technology, the mortality benefits are likely underestimated, and I think we're doing better than that, and the newer methods of screening really are superior, which reduces the harms, and so that can really change the balance and hopefully make it more palatable for women. It is a personal decision, and obviously there's a lot of factors that have to be taken into consideration. I think, again, if we want to do better in some of those ethnic groups that have different and more aggressive tumors and a younger age, mean age, we have to do regular screening at that younger age, and it's just not happening. And that's why those pie charts you showed initially does show still a discrepancy, and so I do think we can do better. But we don't, it's obviously an area where there's a lot of confusion on. So thank you, and I'm sure we'll have more questions after.